California Pediatrics, a podcast by pediatricians from the 4 California chapters of the American Academy of Pediatrics, AAP California Chapter 1, 2, 3, and 4. 4 chapters, 1 state, 1 voice. In 4, 3, 2, 1.
Hi, I'm Dr. Michelle Leff. I want to welcome you to California Pediatrics, where we discuss topics of interest and spotlight on the professional trajectory of our guests.
And I'm Dr. Marcia Spitzer. Our guest today is Dr. Kumar, and we'll be discussing her journey in adolescent medicine. Dr. Kumar, thanks for joining us.
Thanks for having me. I appreciate it.
So maybe you could start out by telling us a little bit about your current position.
Yeah, I am an adolescent medicine physician, and I work in both an inpatient and an outpatient setting. So I work in an outpatient adolescent medicine clinic, and I see young people as young as, 8 or 9 years old, and my oldest patients are up to 30 or their late 20s. When I work in the inpatient setting, I take care of patients who have medical complications of eating disorders. And then we're doing inpatient medical stabilization for people who are very ill from their eating disorders. So that's the clinical part of my job, but then I also have an academic appointment with the university. So I get to teach medical students and residents and fellows, and I work on scholarly projects. Some of that is original research, but I also like to write books and book chapters and case reports, and a lot of that is done in collaboration with other adolescent medicine people from across the country or around the world, which is a lot of fun and a nice opportunity for me. And the other thing that I take on are some administrative tasks just in my clinic. So I'm a clinical director, so part of that includes just kind of helping to support the everyday operations of my clinic and its staff.
I'd love to hear a little bit about what brought you to this career. How did you decide on adolescent medicine?
That's a great question, because I never, ever planned to do this. I think if you asked me when I was a kid what kind of doctor I would ever be if I was going to be a doctor, I don't think I would have known adolescent medicine was a thing, or that it was what I might have wanted to do. I think that even though I wanted to be a doctor for a long time, my mental picture of what a doctor was like our family doctor. And I think I just kind of wanted to be him, because I really appreciated how my family just had absolute trust in him. My family was an immigrant family. You could see the difference in their comfort level when they went to see him, who was also, of an immigrant background, versus if we went to like an urgent care or something like that. My grandmother in particular, who I lived with, who helped to raise me, and English was very much her like second language, always put full faith in what this doctor would recommend for her or for anyone else in the family. Then we had a problem, it was like, let's go see Dr. So-and-so, you know what I mean? And I don't know that I really had an appreciation for like the medicine he practiced. It was more that I liked that we had that relationship with him, and I wanted to have that relationship with people. So not knowing a whole lot, because nobody in my family was in medicine or anything like it, I went to college and I started medical school, and I still was thinking about my, family doctor and thinking, oh, well, maybe that's what I'll do. Maybe I'll also become a family doctor. And I got to spend some time shadowing an emergency room physician. And again, it might have just been that he was such a cool guy. And I really enjoyed the variety of patients that he was seeing, that I thought maybe that's what I wanted to do. And when I was in the middle of medical school, I went to India for a global health elective, which was supposed to be in emergency medicine, because I thought, oh, this will be really cool. I'll do it in like a new setting. And I got there, and I was supposed to spend 6 weeks doing what they called accident and emergency medicine over there at a Indian like medical school. And I got there, and they're like, who are you? And I was like, I'm the student from Canada. I'm Canadian. Who was supposed to be doing an elective here in emergency medicine. And they're like, oh, we don't have that. And I was just, I had just gotten there. I had spent a lot of money that I didn't really have at the time. And I'd taken like a, 30-hour flight because I took the cheap way, not through Europe, to get there. And they were saying that they had no record that I was supposed to start. So they said, we could probably squeeze you into emergency medicine for like a week or two. But that's kind of all we have space for because like we have our own trainees. So you could pick something else. You want to try something different? And I was just like, I mean, what's available? And they said, peds is available. Pediatrics is available. And I was like, okay, I guess I'll do pediatrics. And darned if I didn't end up liking it a lot more. I did not expect this. I came back feeling very conflicted. And I did a few more electives in pediatrics and I was like, this is cool. I really like this. I like the developmental aspect of it. I still wasn't sure though, what I wanted to commit to. And then I was doing a rotation in obstetrics. And I was working in kind of an inner city hospital. And in those days, I don't think they would do this now, but they let the medical students do the deliveries with supervision, obviously. But so many of the parents that I worked with were teenage parents. Mm-hmm. And most of them were from underserved communities. And I found myself, when these babies were getting delivered, baby would come, everybody was rushing around the baby, checking if the baby was breathing, checking if the baby was pinking up and all those good things. And I couldn't take my eyes away from the mother when that was happening. And one of the things that I noticed was that, especially some of the younger ones, because I remember the youngest mother whose baby I delivered was 13, and it was her second baby. And, when you think about 13-year-olds, there's this lovely kind of spark that 13-year-olds have. Like, it's kind of the last age where you still believe that you could be an NBA player, or you still believe you could make it big in the music industry. Do you know what I mean? Like, you still have that. And there's a lot of, things that drive parents crazy, like talking back and questioning everything. But it's kind of lovely, right? Like, there's a spark there, and no spark. Like, none. And that bothered me. And I found myself unable to sleep thinking about these moms who are in fact children. And just thinking, like, in all the pediatrics I've gotten to see so far, it really has been about younger kids. And even when I thought back to my time in India, the cases that were most compelling for me were the teenagers. And after a lot of sleepless nights on that rotation, I decided that I wanted to do pediatrics to work with teenagers. And I didn't actually know that adolescent medicine still at that point was a specialty. And then when I started looking for, more pediatric electives, I found that there was this thing called adolescent medicine. And it wasn't offered in very many places. In Canada at that time, there were only 2 fellowship programs, one on each side of the country. So I flew across the country and I went to visit one of them, and I spent a few weeks there when I was, I think, a 3rd or 4th year medical student. And it just, I fell in love. I mean, it was exactly the right thing. And it was kind of interesting because, yeah, I never planned it that way. It just sort of happened. But looking back, I think that when I think about just life experiences even that were really important for me before I went into medicine at all, they typically involved working with teenagers or being a teenager, one of the two. A lot of my volunteer and extracurricular stuff involved working with teenagers. I used to coach teen extracurricular kinds of activities when I was a college student, At one point, I had a summer job working for a First Nations youth agency, and I was like a youth worker there. And that was one of the most fulfilling jobs I ever had at like 19 or 20 years old. And so fast forward, I feel like I'm in kind of exactly the right place at exactly the right time. And so now I've been working in adolescent medicine for 15 years. And I get older and they stay the same age.
I was actually, thanks for sharing that. I was thinking about that as you were talking.
Yeah.
That when you first started, you were much closer in age
Yes.
to your patients, and you're not now, right, as we all get older. What have you learned, or what's different about your interactions with teenagers now, you think?
You know, the interesting thing is I'm not sure it's changed that much, because one of the things I learned early on is don't try to be cool. Like, it doesn't go well. And the second thing I learned is once you are like over 25, you're old. You know, and it almost doesn't matter if you're 25 or 35 or 45, you're just old. You're out of their world at that point, right? I find it is very helpful to just embrace it, because I have discovered that teenagers enjoy a fun old person more so than a person who tries to be young or that kind of stuff, right? So I will often hear things that they say and I'm like, I'm old, so can you explain that to me? And they love it. They love to share, you know, little pieces of their world with me.
I was going to ask you how you stay up on what's, you know, current, the terms, and
I just
you know.
ask. You know, I'm like, so what do kids call marijuana now? You know, I have to ask every couple years because it changes. Or people will use a word and I'll be like, what was that word you just used? I feel like I haven't heard that before. And they're like, oh, you haven't heard that before? Oh, that's adorable. And then and then they fill me in. So, you know, I just let them tell me. Yeah, I feel like it helps to not act like you're like, because otherwise you end up sounding like a high school guidance counselor. You know, you're like, you can talk to me. Do you know what I mean? And I don't like that vibe. You know, I would not have liked it when I was young, and I find most teenagers don't like it either. I think you just kind of have to own who you are. You're not a teenager anymore. But that doesn't mean you don't remember what it was like to be one, which is, I think that's definitely true for me, and it does help me a lot. You know, just being able to say, I can imagine how that would suck, or I can imagine how that would be frustrating. You know, like, you have your worldview, and your mom saying this to you totally sucks. And you can just sort of validate their experience for what it is.
I think that's really true, right? I mean, teens, they just want to be heard for the most part. And I think nothing makes a teenager happier than to teach someone older than 25 something that they know a lot about and that other person doesn't.
Totally.
Right?
Yes.
Yeah, my son loves it when I ask a question on my iPhone.
Yep.
Yeah.
What are some of the topics or, you know, areas of medicine that are different for an adolescent medicine doctor than a general pediatrician?
The funny thing is, I mean, I would say that most of what I do, I think a general pediatrician could also do. Do you know what I mean? Like, I think it's more about having the developmental comfort and also just the experience of doing it a lot. Because I did do general peds for a while, like before I finished my fellowship and had the training to actually start doing this full time. And when you don't see a lot of teenagers, you just don't get as much experience with managing, for example, like gynecologic concerns or urologic concerns or menstrual problems or prescribing birth control or those kinds of things, right? I mean, if you happen to be a general pediatrician who sees a lot of that in your practice, you're probably actually very comfortable. But most pediatricians don't have a adolescent heavy practice. That's for lots of reasons. Sometimes it's provider preference, but I think more likely it's because kids kind of stop coming for preventive visits, you know, when they reach a certain age. I mean, parents are going to bring their kids diligently when they're infants and even when they're, you know, school age kids, and then something sort of happens and then they only go to the doctor when they're sick, which is like not very often, right? So you may just not get as many opportunities. Whereas I have a captive audience. All my patients are teenagers, so I get lots of practice. And so I would say a big chunk of my practice is eating disorders and nutrition concerns, which is actually starting to spill a lot more into work with kids who have higher BMIs, just because I think there's a lot more understanding now that taking a weight inclusive approach to people who have things like type 2 diabetes or dyslipidemia or those kinds of things is more effective and more sustainable. And having an eating disorder background actually really kind of prepares you well for doing that kind of work. So I feel like I am seeing more kids with, for example, like binge eating disorder, whereas before I used to see kids with more like traditional, I guess what you might think of as traditional eating disorders like anorexia or bulimia. But now I feel like I see all types, including kids who are having diseases related to adiposity that they have concerns about or that their parents have concerns about. And your relationship with food and yourself is still like very core to like a lot of those conversations. So, and then the other big chunk that I tend to do a lot of is reproductive health, which is mostly management of menstrual concerns, but also pregnancy prevention and just like crazy things your body does when your hormones fluctuate, like getting seizures or getting migraines and things that can actually be helped by suppressing periods or suppressing ovulation. So, I always thought it was concerning and interesting that we don't talk about it more, that period-related symptoms are the number one cause of missed school and missed work for assigned females at birth, like across the globe. And so it's kind of surprising that more attention isn't like given to that as a concern, right? And that it's sort of normalized that 1 week a month of your life is just going to be terrible for the next 3 decades. Do you know what I mean? And so I really enjoy having conversations with kids and their moms about how it doesn't have to be that way. And their moms are like,
someone should have told me.
Right, yes, exactly. And even things like longer acting birth control methods like IUDs or subdermal implants, which I think traditionally were thought to be more for older women, but are actually very suitable and appropriate for teenagers. And there's a lot of fear and misinformation around those things, aggressively fueled by social media. But being able to have those conversations with kids, I find it so funny how like moms and aunties and grandmas who will often come to visits are like, I've been struggling with this my whole life, and I never got an opportunity to have someone explain it to me. And no one ever offered me help for it. So that's really gratifying, is to kind of raise these topics. And, I like the idea that like families are going home and talking about it differently.
Well, I love hearing about your journey. Maybe you could tell us a little more about any advice for medical students, residents, or new attendings who would like to get more comfortable with adolescent medicine.
I think, and I feel like I have this conversation with general pediatricians a lot, is you don't have to be an adolescent medicine doctor to practice adolescent medicine. I think that there often is some struggle with what's on the surface when you treat people in this age group. Because suddenly it was hard enough having like a child and a parent and yourself all engaging in shared decision making. And now you have a teenager and a parent and yourself, and now there's another loud voice in the room that wants to be heard, right? And it doesn't have to be frustrating or scary if you remember that your job is not to be their parent, and your job is not to be their friend. Your job is just to be their objective third-party doctor. And actually, I get way further when I think about it that way than feeling like I have to like get this kid to see straight. Do you know what I mean? Because that's not my job. So I just think of it as, consider yourself almost like a third objective party in the room that both of them can ask questions of, and then they need to work it out. That tends to go really well. You build rapport with both of them, and they seek you as a trusted source of information. And it makes me really happy when teenagers reach out to me independently of their parents to ask a health question because they know they can. So we can all do that if we have teenagers in our practice. It makes you feel more sane and more empowered, and it makes you don't have to do things that aren't actually your job.
I think that's a great transition to a question of what tips do you have for that parent
in
that room, and how advice they have for those appointments and those interactions.
Yeah, it's so hard. I mean, being the parent of a teenager is like, I have a lot of respect for parents who are going through that particular stage. I think that the first thing I would keep in mind is they will always need you. That will never stop. You may just want to rethink, though, what they need of you. And that at this time, your job is to help them feel happy and confident about the idea of being independent when we live in a really scary world. And that's hard. But they are always going to need you. Let them know that. Let them know the things that you can still help them with, even as they grow and separate in some ways and learn to function as independent, world citizens, that you're never going to leave them hanging. And even though I say this as a person who cried when their kids, started their first day of school and things like that, and I'm going to keep doing that. But there's actually nothing more lovely than when they realize that they can do it. And they're still going to need you, so you can have the best of both worlds.
Great advice. What a great way to end our podcast. Thank you so much, Dr. Kumar, for being here today.
Thank you so much. It was a pleasure being here. Thanks for having me.
I so enjoyed listening to Dr. Kumar. She clearly has so much passion for the adolescent age group, and it's a really good reminder to me about the joys of working with all different age children.
I agree, and I was thinking a lot about what she said about sort of being the third person in the room. And I think with my own children when they were teenagers, and at one point one of my kids looked at my husband and me, said, "I'm not trying to get you to solve this. I need you to just listen." Right? And that's one of the most important things I think she really talked about, is just listening to kids and letting them speak is one of the best things we can do as parents or as pediatricians.
We might learn something.
Yes. Well, thank you so much for joining us.
Thank you.